Moving on to our next session, I would like to invite Dr. Lakshmi Narasimha Reddy, cardiologist at NH Indupur, and Dr. Praveen Gangadhara, who is the consultant diabetologist at Dr. Mohan's Diabetes Specialty Center at Malleshwaram, Bengaluru. Over to you, chairpersons.
It's on. Can you take this? Yes.
Good evening, one and all. It's my honor and my pleasure to introduce our speaker today, Dr. Anil Kumar Virmani, sir, who is a well-known senior physician, consultant physician, and diabetologist at Brahmananda Narayana Multispeciality Hospital from Jamshedpur.
No. That's wrong. It is actually.
Sorry for that, sir. Anyways, Virmani sir is a well-known senior physician and diabetologist, well-known speaker in most of the national and international forums. We're happy to hand over the session to him on restoring the warning signs of cardiometabolic disorders.
Honorable chairpersons, and good morning to all of you. I must thank Dr. L. Srinivas Murthy for inviting me here today. If you don't know, he is one of the best researchers, genuine researchers we have in our country. He is the foundation of this conference, and since I call him LSM, he is also the foundational treatment of all metabolic diseases, because LSM also stands for lifestyle modification. So he has given me this topic, how to restore the warning signs of cardiometabolic disorders. No disclosures. Now, to introduce what is cardiometabolic syndrome, it basically represents a constellation of metabolic abnormalities, including abdominal obesity, which is the most important, insulin-resistant glucose metabolism, dyslipidemia, hyperuricemia, and increased blood pressure. And these are the risk factors both for cardiovascular disease and type 2 diabetes, and they increase the risk of coronary heart disease, myocardial infarction, and stroke. The underlying mechanisms intertwine genetics, sedentary behaviors, poor diets, and hormonal imbalance. So both genetics and epigenetics and environment. Chronic low-grade inflammation, often missed, driven by multiple factors, including adipose tissue dysfunction, oxidative stress, and immune cell activation, is characterized by heightened levels of inflammatory markers such as interleukins and tumor necrosis factor alpha, and plays a central role in the pathogenesis. The objective of my talk today is to understand the early warning signs and restore the metabolic health to original. Now, if you look at the course of cardiometabolic disorders, right, the risk factors here, hypertension, diabetes, obesity, elderly, they can have endothelial dysfunction, microalbuminuria, proteinuria, nephrotic proteinuria, and end-stage renal disease. Or they can have atherosclerosis and left ventricular hypertrophy, MI, stroke, remodeling, ventricular dilatation, cognitive dysfunction, congestive heart failure, secondary stroke, end-stage heart disease, brain damage, dementia, and cardiovascular death. So it is basically a risk is based on the concept of a continuum. And we have to break this continuum if we want to restore metabolic health. But the basic culprit is the adipose tissue, and we must understand that. And what does it lead to? It leads to increase in the free fatty acids, and they impair insulin action, both in the skeletal muscles as well as the liver, leading to hyperglycemia. They stimulate the hepatic VLDL triglyceride production, decreased HDL, leading to the major consequences of hypertriglyceridemia, which is the foundation of the Indian dyslipidemics. And they also stimulate vasoconstriction and increase sodium reabsorption, possibly leading to increased blood pressure. And the basic culprit lying in the core is the insulin resistance, and you can see it is surrounded by all the manifestations of the cardiometabolic syndrome, like type 2 diabetes, hypertension, IGT, obesity, polycystic ovarian disease, hyperuricemia, the acanthasis nigrosis, decreased fibrinolytic activity, dyslipidemia, and atherosclerosis. The prevalence, in Asia is around 22%. The clinical implications of the cardiometabolic syndrome, there is a 5-fold increase in type 2 diabetes, 2-fold increase in the cardiovascular disease, and elevated risk of what is now called the MASLD and certain cancers and sleep apnea, and 40 to 50% prevalence of polycystic ovarian syndrome. The story started with coining the term metabolic syndrome. And there have been a number of definitions, but I will follow the latest definition given by the International Diabetic Federation. And this is the curse of progress of human beings. And this metabolic syndrome is the result of this curse that God has given us. So the definition of metabolic syndrome is basically abdominal obesity plus two other components, either elevated blood pressure, low HDL, elevated triglycerides, or impaired fasting glucose. And if you look at the cutoff levels, when we talk of abdominal obesity, it is the waist circumference we are talking about, not the BMI, because the waist circumference correlates in a much superior way as compared to the BMI, and the cutoff is more than 90 centimeters for men, more than 80 for women, triglycerides more than 150 or on treatment, HDL, men less than 40, women less than 50 or on treatment, blood pressure of more than 130/85 or on treatment, and a fasting glucose of more than 100 or on treatment. So these are the cutoffs for defining the metabolic syndrome. But the metabolic syndrome definition, let us analyze what implications it has. The clinical utility of this syndrome is that to remind the practitioner that there are certain risk factors that tend to cluster within individuals. That is the main utility. As far as the public health problems is concerned, it is to highlight the clustering of risk factors associated with obesity, particularly abdominal obesity and physical inactivity, so that we can tell them not to be physically inactive. But the global consensus definition was immediately followed by a joint statement from the AD and ASD questioning the use of the term metabolic syndrome. What did they say? They said the statement concluded that too much critically important information is missing in this to call it as metabolic syndrome. And it was also argued to just have a label of metabolic syndrome does not add any risk in addition to the risk contributed by the individual items. Now, moreover, there was a question of universal applicability to all the ethnic races and gender. So what happened? This was the metabolic syndrome. It was considered to be a new cardiovascular risk factor. Then we saw there were other factors, the global CVD risk factors like glucose, LDL, age, male sex, smoking, family history, and whatnot. And when you combine together, this is what is called the global cardiometabolic risk or the global cardiovascular disease risk. So it is the presence of metabolic syndrome, but also traditional risk factors such as lipids, blood pressure, glucose, age, male sex, smoking, and often genetic factors which we are unable to delineate. Now, let me give you a concept of what is hypertriglyceridemic waste. This is a very important clinical concept that you can use it in your day-to-day clinical practice. We have something called the functional adipose tissue, and that is a good normal adipose tissue. If you look at it is normally in the subcutaneous tissues. It is a favorable genotype, healthy diet, physically active, insulin sensitive. So if you measure the waist circumference, it may be increased, but the triglycerides are normal. On the other hand, we have what is called the dysfunctional adipose tissue, where the adipose tissue is in the visceral organs. So unfavorable genotype, unhealthy diet, sedentary, insulin resistance. So you have an increased waist circumference and elevated triglycerides. So you can see the difference just by measuring serum triglycerides. So what it shows? That in the presence of an elevated waist circumference, fasting hypertriglyceridemia is a simple marker of the subject's relative inability to store energy in the subcutaneous tissues, which acts as a metabolic sink, and that is where the functional adipose tissue is there. And this is a simple marker of the dysfunctional adipose tissue and its associated metabolic complications. So in other words, it is a red light signal that tells you, please warn the patient or treat his hypertriglyceridemia. A simple thing that you can follow in your day-to-day clinical practice. And we know it is correlated with all bad adverse outcomes, the increased risk of cardiovascular, coronary artery, aortic calcification, type 2, and etc., etc. But even better than that is what is called the index of central obesity was introduced. Now, this is the ratio of waist circumference to the height, and this is suggested as an alternative. It has got a strong correlation with the leptin levels, atherogenic lipid profile, oxidative stress, and increased cardiovascular risk. And there is no need of any ethnic, race, gender cutoffs. And the message is simple. Your message that you give to the patient is, if your waist size is more than half of your height, you should consult your doctor. You are having metabolic problems. So two things, raised triglycerides and your waist circumference more than half your height. These two things I think you can daily follow in your clinical practice, and these are the high-risk patients that you need to take care of. Now, what are the advantages of calling it cardiometabolic syndrome and not metabolic syndrome? This is operational. So if something is left out, we can always add, like the liver enzymes, insulin levels, EGFR, albuminuria, and there can be, you can keep on having predicting models and equations. And it encourages providers to look for other risk factors. But what is most important? It encourages behavioral therapy as opposed to just treating every risk factor on its own. It's a better predictor of diabetes and cardiovascular disease. So what are the risk factors of cardiometabolic syndrome? As I said, obesity, particularly abdominal obesity, sedentary lifestyle, unhealthy diet in saturated fats and sugar, high salt intake, family history of hypertension, metabolic syndrome, smoking and alcohol abuse. How do we prevent and manage? Maintain a healthy weight through regular exercise and a balanced diet. Monitor all the parameters like blood pressure, cholesterol, blood sugar regularly. Reduce salt intake and avoid processed foods. When I say reduce salt intake, there have been a lot of controversies how much salt to take, but in our tropical country like ours, I said 3 grams, if you can reduce it to 3 grams per day, you are getting all the benefits. You will reduce coronary heart disease by 60 to 120,000 per year, reduce stroke by 30 to 60,000, reduce MI by 45 to 99,000. And that is half a teaspoonful, because 1 teaspoonful is 6 grams. So half a teaspoon per day salt is more than sufficient. Limit alcohol consumption, no smoking at all, manage stress with and ensure adequate sleep. We often forget what is good quality sleep. Now, it is basically means that you typically fall asleep in 30 minutes or less, sleep soundly throughout the night with no more than 1 awakening, and drift back to sleep within 20 minutes if you do wake up. And this is the exact definition of what is a good sleep, so around 6 to 8 hours. Now, weight reduction, how do you do it? It's basically calorie reduction, increased physical activity, and behavior modification. These are the 3 pillars. It is not the GLP-1 receptor agonist or the SGLT2. They are just simple tools that will give you a temporary relief. But the basic, if you want a permanent treatment, it is calorie restriction, increased physical activity, and behavior modification. When I say calorie restriction, decrease the amount of carbohydrates, increase the proteins. The aim is to decrease liver and the pancreatic fat. Now, these are the weapons of mass destruction that the US was talking about. The diet, if you reduce 500 kilocalories restriction daily, is equivalent to reducing weight 1 pound per week. That is sufficient. You don't have to be over enthusiastic. So if you restrict, have a very low carbohydrate diet, it acts only for a few weeks, then you come back to the original. It is, the more important is adherence to the diet, which rather than choosing which diet. And I call it the SNAP diet. And what is the SNAP diet? It stands for sustainable, nutritious, affordable, and palatable. If these 4 factors are there, then this is the best diet you can have. And then it must be a high quality diet, sodium restricted, enriched in fruits, vegetables, whole grains, lean poultry and fish, and should be encouraged to give the overall health benefits. Physical activity, the ADA recommends 150 minutes per week, but the Asian recommendations given by Dr. Anu Mishra et al. Are at least 60 to 90 minutes of daily activity. And you can gradually increase it, and to enhance adherence, patients may require pre-exercise or pre-counseling depending on their cardiac condition. The formal exercises like jogging, swimming, tennis, routine activities are more than sufficient. But even resistance exercises are now being recommended, strongly recommended at least 3 times a week. Now, there are certain foods we often miss to tell the patient not to take. And they're simple foods like baking powder, fried foods, achar, papad, which everybody will take. You restrict salt to less than 3 grams, but the patient has a lot of papad and achar, it makes no sense. That's all the hidden salt. And you can see the difference between a person who is healthy and the person with the cardiometabolic syndrome. A classical difference when you ask him, this is what you will see. So how do you change the course? I showed you the course of cardiometabolic disorders. The present concept is we prevent it, early control of risk factors, and further events can be prevented. Regression here, therapeutic approaches can regress cardiovascular and renal damage, and everybody is talking about the cardiorenal drugs today. In the late stage, we have measures to retard. This is the conventional, but I don't believe in this. What I believe it, I will bring the regress portion down below and I'll say start therapeutic approaches here. Start your SGLT2 inhibitors right here. Don't wait for him to go there. Why? I'll give you a simple example. Now, if you start an SGLT2 inhibitor, when the patient's eGFR is around 20 ml per minute, you delay kidney replacement therapy by 1.9 years. But if you start when the eGFR is around 83, somewhere around here, you delay kidney replacement therapy by 26 years. See the benefit you are getting if you start it earlier. So what is the message I want to give you? Hit early, hit hard. Early use of combination therapy to get the legacy effect. Somebody was talking about stepwise therapy. Never use stepwise therapy in these things today. We are having a proactive approach. Use the right combination. Be holistic in approach. Try to cover everything. Remember, glucose control is also important. Even though the ADA and the guidelines say you give these cardiorenal drugs irrespective of A1C, I don't agree. You must take care of A1C also. Don't forget to take care of A1C. And use the pleiotropic effects in cardiorenal drugs. Use the weight-lowering drugs judiciously. Don't keep on jumping, writing Wegovy and Mounjaro to every obese patient that you see. They do have a lot of side effects. Choose it judiciously. Improve adherence and quality of life. 60 to 70% of the patients on these GLP-1 drugs stop taking it after 6 months. Even forget that, even the normal antihypertensive drugs, the adherence rate is very poor. So the key messages that I want to give you, despite a lot of controversy, the cardiometabolic syndrome, which is an interesting constellation of maladaptive cardiovascular, renal, metabolic, prothrombotic, and inflammatory abnormalities, is now recognized as a disease entity by various bodies. These derangements individually and interdependently lead to a substantial increase in cardiovascular disease morbidity and mortality. It is an established and strong risk factor for premature and severe coronary artery disease and stroke. Visceral obesity is the key culprit. It is very important that we do early detection and multifactorial intervention. The established and evolving treatment strategies include moderate physical activity, weight reduction, rigorous blood pressure control, correction of dyslipidemia, glycemic control with cardiorenal protective drugs. So a holistic approach. But remember, it is the behavioral modification which is the most important. So unless you improve the patient's attitude and behavior, none of this is going to work. As simple as that. And collaborative efforts between the individual and healthcare providers can significantly reduce risk. If the patient is not motivated, if he is not well informed, if he is not involved in the treatment process, he will never follow your treatment. Please take it. And I'm telling you from 48 years of clinical experience. Evaluate and treat all cardiovascular risk factors without regard to whether or not a patient meets the criteria of the diagnosis of cardiometabolic syndrome. And this is a wonderful message. This is in Hindi. मेरे दर्जी से आज मेरी जंग हो गई, कल पैंट सिलाई आज तंग हो गई. Don't blame your tailor for getting obese. Thank you.
Thank you, sir, for your excellent presentation. And I thank Dr. Srinivas Murthy, sir, who has given us chance to chair here. And I have a question, sir. Sir, I have a doubt regarding low carbohydrate, high protein fat diet.
High protein?
High protein fat diet with low carbohydrates. In controlling.
See, what do you mean by low carbohydrate? As it is, minimum of 130 to 150 grams of carbohydrate are required. I do not believe in very low carbohydrate diets. It has to be adequately balanced. High protein is good. Fat should be moderate. Carbohydrate should be around 40 to 50%, 45 to 50%. Because right now, as Dr. Shashank Joshi has shown that our carbohydrate intake is somewhere around 70, 75%. So bringing it down to 50% is more than sufficient. You don't have to go down below. But a high protein diet gives you early satiety and it allows you to eat less so that you don't gain weight. So high protein diet is always good.
High protein diet regarding to renal problems, sir.
Sorry?
High protein diet.
Yeah, that's what I'm saying. That's a high protein diet, but with adequate carbohydrates and fat. Try to put what fat we are reducing 20%, put it on the protein side.
Is high protein better or high fat better, sir? When
high protein. High protein is always beneficial.
Any questions by audience, please?
Take the high fat diet, like drinking coconut oil, so many things are there.
High fat diet.
High fat diet, sir.
See, high fat diet I will never recommend. There are, if you go in the Google, you will find there are thousands and thousands of diets.
Yes, sir. Taking
And
ghee taking.
every day somebody comes up with a new diet, started with Atkins, Ornish, Mediterranean,
And
even
people are
Mediterranean
following
diet.
that one, sir.
See, it is
But,
not possible for Indians to follow Mediterranean diet. How many of us can afford to use olive oil? And olive oil cannot be used for cooking purpose, heating purposes. So, as I said, no matter what diet you follow, as long as it is adequately nutritious, well balanced, because you have to sustain it throughout your life. It should be affordable to you. I can't tell you take 2 grams of olive oil daily. It's not possible. And it should be palatable. If it's not tasty, high fat, how long you will take high fat diet or very low carbohydrate, you can't take it. It's meant only for clinical trials for a very limited period. But when you are talking to your patients and they are going back home, they are not going to follow the diet that you tell them, give high carbohydrate or low carbohydrate or high fat. They are not bothered. You have to specify what you have to take.
what about daily taking 3 eggs? They're telling to increase the protein intake.
Protein intake related to?
Eggs.
Eggs.
Whole egg, sir.
Daily three eggs per day, is it okay?
3 eggs.
Yeah.
3 eggs per day.
Yes, sir.
I don't
People
know.
are eating 6 eggs.
The recommendation is to take around 5 to 6 eggs per day, per week. And the white portion you can take as much as you want because that is high protein. Avoid the yellow portion. But safely you can take 5 full eggs in a week. That is not a problem.
Eggs should not be a problem. Our protein intake is legs.
And that's why people are taking 3-4 eggs,
so even
per
the yellow
day.
has some amount of healthy fat. So it is not, unless you kind of roast it, do a kind of a
And
bhurji.
let me tell you, the high protein, whatever you are taking, of vegetable origin is far superior as compared to the animal origin. You have sprouted chanas, you have rajma, you have soya beans. We have lot of good high protein components in the Indian diet.
Madam,
Thank
the
you,
entire egg, we usually get nearly 6 grams of protein, and in the egg yellow, we have 2 grams of protein. If we avoid this yellow, we lost 2 grams of protein from that.
Okay.
Yellow is not a problem. It's not a, I think sir will be putting light in the coming talk. I think we'll be talking. So Yellow is not a problem as long as, I think it's a good source of protein, vitamin D.
One more question, sir. What about the soya beans?
Should be okay.
Some
Soya beans are
people-
very
Good
good.
source of
Very
protein.
good.
Soya beans, rajma, they are very
But
good.
they're telling
The green-
soya
all
beans
green
are
leafy
not good
vegetables.
for the Indian origin people. Soya beans, because certain people, they cannot digest and
That's psychologically, we people have issues with any lentils, any sundal, you talk, the moment you'll tell us gas, bloating, but the point is, our protein intake is dismal. That's the point. So this causing a bloating issue is more in the mind rather than, I think when you restart and reduce the carbs, if you have to sustain a low carb, you need to up the protein and the healthy fats. And again, when I talk about fats, it's the nuts, you have your avocado, you have your fish, salmon. So it's all about, if you want to sustain low carb, you need to up the protein and the healthy fat.
so our old age method is like dosa, chutney. It's good,
So
huh?
include a cup of sundal along with that.
Okay.
That should do the job, rather than changing into ragi dosa, millet dosa.
Yeah, including some
Egg or sundal will do the job.
vegetables, uncooked vegetables.
Yes, yes. But protein will give you the satiety.
As it is, you know, the average protein intake in our country is around 0.5 to 0.6 milligram per kg body weight.
Yes.
Whereas the recommended dose is somewhere between 0.8 to 1. So we are already having very low proteins, but we are having high carbohydrates. So the message being given is reduce that carbohydrate by 20%, increase the protein by 20%. That will give you an adequately balanced diet.
Thank you, sir.
Thank you very much, sir. Thank you. We'll close the session here. Thank you.
I would request the chairperson to give the memento to the speaker. Thank you so much for enlightening us with your talk, sir.